Okay, so I'm going to talk a little bit about family support and siblings, but more on the younger end. So we just had a conversation about adults and the importance of family. So family supports start early and they go through a lifetime with any child, with autism or not. So I thought we'd talk about 3 topics. First, what are the goals of family interventions, family-centered interventions? What's the evidence for those? And what are some new areas to think about? Okay, so goals of family-based interventions. First, oftentimes it's to increase access to information and support. So kind of like these kinds of conferences that bring people together, it's really sharing of information and giving access to families with this kind of information. And then also to provide some support for families, so families meeting other families. And then a second big area is to really increase the dose and generalization of child-centered interventions. So yes, the child has autism, and for probably the majority of children, they need specialized interventions. I would argue that some children might not need interventions that are that different or targeted or specific, but the majority of them will need those interventions because they have delays in language or social or something. But those are child-centered, and there will be many different programs that child will need over the lifespan, and many people will come in and out of that child's life. Teachers, specialists, and the only one constant that child has is really the family unit. And so the family becomes really a very important part of this child's treatment plan. And I think in the States, we've worried a little bit about parents taking on the complete intervention role. So you're a parent and you're the interventionist. So there is that balance that parents have to think about there. But parents do have this role of being the advocate for their child throughout the lifespan. So we start with little ones and we start with binders. We just start gathering all the information about this child and things that work and things that don't work and different doctor's appointments and the results of those all in a binder. You just hang on to it so that you have it throughout the lifespan and you're the one constant for that child. So when we do direct instruction with parents, there are a couple of different models. So one is parent education groups, and these really vary. They can be things like the WHO parent support, what is it called, PST. I know it is PST, I don't even know what it stands for. But that's really a group-based information sharing about autism and behaviors and education, and some one-on-one coaching, but very little one-on-one coaching. It's mostly learning within a group context. So we think about those as more parent education models. And those are really important and can be really powerful. At the same time, they don't get the same results as some of that hands-on coaching does with your specific child, because your child is unique, and you may have unique questions and unique needs. And so hands-on coaching is another way of having interventions. All right, so there are in the States several interventions that are more parent education. So they provide information. They talk a lot about how do you engage your child, how do you change some of those core impairments, how you deal with behavior challenges. But they don't work directly with you so much. So Hannon, More Than Words, is a program that's really nicely packaged and great for parents, especially of young children. So I don't know if that's translated in your language, but it's a great book with a lot of good information. Brereton and Tong is out of Australia. It's another very nice book for preschool-age children on sort of behavior challenges, autism, how to reduce stress related to raising a child with autism. It's another one, if it's not translated, probably should be. And then the parent strategies, is that what it's called, Andy? Parent strategies training from WHO, Autism Speaks. So those are all good examples of parent education models. Then there are parent-implemented hands-on interventions with children, and there are lots of examples. So Jasper, the one I was talking about earlier, we do a lot of parent training using that model because it really focuses on that module of core impairments. So joint attention, joint engagement, play skills, communication. There's another one called Project Impact. It's a little similar but more behavioral, more focused on pivotal response training. ESDM is another one that's a little bit more behavioral. PACT is out of England, and it's definitely not very behavioral, but it uses a lot of video feedback with parents as part of the education. It's quite nice and has some nice results. ESI is based on a CERTS model, also not very behavioral, and Play Project, which is based more in floor time. So you have this kind of range of parent hands-on training from pretty behavioral, more behavioral kinds of direct instruction approaches to very naturalistic, following your child's lead models. And there's varying evidence across these models, some with no evidence and some with quite a bit of evidence. That being said, they're packaged nicely and you can pick them up and you can translate them. So those are all really for young kids, but of course you have your child through the lifespan and your needs change. So there are some nice parent-partnered interventions for adolescents and young adults. One of them is the Peers Project, which is about developing friendships for your child with autism who is verbal high functioning. Right? So it's nice because it works with the adolescent or young adult in a separate group, and they work with the parents in another group. And so, you know, I've raised a couple of adolescents, and I don't think they would want me involved in their friendship development. But autism is very different, and the kids seem to enjoy having their parents involved in this process, and parents can actually help with setting up and monitoring those get-togethers that they might have with friends and kind of motivating them to actually reach out to other kids. So that's a nice model. And then there's another one that's in progress. I haven't seen the evidence on it, but it sounds very good. It's called Transitioning Together, and it's around that process, that transition process of from high school into college or work or life. And it's transitioning together, meaning the parent and the child, you're both going through a transition, and there are strategies for how you work that through together. So I'm hoping that they have some evidence soon, and it sounds like a nice program. And then there are specific targeted programs for some of the comorbidities that we see in kids with autism: anxiety, depression, obsessive compulsive behavior. And the go-to therapy model is cognitive behavioral therapy, and there are autism researchers who have now adapted CBT, cognitive behavioral therapy, for individuals with autism. And so those are nice as well, and Jeff Wood's program also has a parent component, which I think is really important. So it helps the parents, it helps the child, and those two together is more powerful than just working with the child alone. So in all of these different interventions, the parents are really critical to the success of the child. Okay, so targets for intervention has been an issue when you think about the research studies. So in parent-mediated interventions, the question is always, what should be the outcome? Should it be the parent or should it be the child? So typically the researcher is teaching you as the parent certain strategies to use with your child. And so we could think about different kinds of targets for the parent. We could think about how well you're doing those strategies. We could think about how responsive you are to your child, sort of getting to know your child. It could be just sort of adapting and coping with your child, and reducing your own stress. Raising any child is stressful. For parents who have a child on the autism spectrum, stress has always been rated much higher. So we want to make sure that we're reducing stress, not increasing stress. And so that's been one of the dangers with some of the ABA models, where you are expected to do many hours with your child, where you are the therapist. That can be very, very stressful for families. And so instead of reducing your stress, we're increasing your stress. So I think, you want to make sure that you're balancing that out. For child targets, we think about the kinds of things that a child needs to learn at a particular age. So with young children, it might be social communication and language. That could remain a target all through the child's lifespan if they remain sort of minimally verbal. Play skills are important when they're younger, leisure skills when they're older. Behavior challenges and anxiety can be across the lifespan and something a parent is going to need some strategies for coping with. And then friendships become really important as kids are moving into adolescence, where they often talk about, not having people to hang out with, not having friends. We start with peer interventions at age 2 with kids. We start exposure. I think in our earlier conversations about inclusion, the question was, well, when do you start this? Well, you start it, early. You want to have exposure to other children, whether they're typically developing children, siblings, cousins, or other children on the spectrum. And then, of course, you might look at things that are dyadic. So joint engagement is a dyadic measure. So what's interesting from the research perspective is we have ideas about what the outcome measures are. But when you ask families what they think the outcomes should be, what's meaningful to them is that their sons and daughters get along better, so siblings get along, that they have better sleep. So the kids are sleeping, they're sleeping, and that transitions throughout the day go smoother. We have very few interventions that focus on those things that parents identify as really important. And I think that's a challenge for researchers in the future. And researchers will develop these interventions if they're pushed by parents. Because one thing we know about autism is that almost everything that's happened in terms of the federal government having laws or having more money for research has come about through the work of parents. So it's all been sort of on the ground work of parents that have created almost everything in the United States, from laws to get kids into school, to pushing the government, to NIH to fund more autism research, and so on. So the parents can kind of drive the research agenda and probably need to be a little bit more vocal. And we probably should listen a little bit better. All right, so there have been very, very few studies that have actually looked at home routines. Like when they teach parents strategies, they teach them in the clinic. Whereas where you need those strategies is in home. And home is a very different environment from the clinic environment. So there have been a couple of studies. Actually, Amy Weatherby has one published in pediatrics, and I, the same year, published one in pediatrics, and Amy was part of my group that published a study on home routines. So in our study, our combined study, we went into low-resourced homes in 5 different sites across the country. And we were interested in helping parents play with their children in order to boost those social communication skills, but we were also interested in what was important to them. So we had them identify a home routine, maybe a daily living skill. So a lot of families chose brushing teeth, which turns out to be a challenge. I don't know if it's a challenge for any of you guys. I know in Florida they chose laundry, but in LA nobody chose laundry. So kids didn't help their parents with laundry, but it was things like transitions to mealtime, transitions just across the day. So whatever those were, we worked on those. So across 3 or 4 routines. And actually, in both of these studies, we had significant findings in terms of sort of more child and parent participation together than in the control groups. So outcomes also need to be related to whatever the focus of the intervention is. Sometimes we do these interventions and then the outcome is completely unrelated to what the content of the intervention was, which doesn't make much sense. So a lot of times we do early interventions where we focus on the parent-child relationship or the child's skills in things like joint attention or language. And those are very different than IQ. So we didn't focus on IQ. We are focusing on development. So when you're young, that's going to impact your IQ. But sometimes, IQ is a fairly distal outcome, whereas some of these others are pretty proximal to what the intervention is about. And then other interventions, especially with older kids, aren't focusing so much on the core impairments, but on these comorbidities, things like anxiety, behavioral challenges, friendships, which could be core, but all right. So what's the evidence for peer-mediated interventions? Well, there were a couple of really influential reviews early on, so up to about 2002. And Helen McConaughey from the UK was involved in both of these reviews. And what they found was there wasn't a lot of evidence for the success of working with parents to impact child outcomes in autism. So the evidence at best was conflicting. So some studies worked, some studies didn't, but overall the quality of the studies was pretty low. But since 2012, which was her last review study, there have been a lot of randomized controlled trials. And all of these that I selected were pretty well powered, so over 60 kids, some of them over 100 kids. So now you have much more evidence that parent-mediated interventions are working. So sometimes we rely on these review papers, but they're old. So just since 2012, there have been quite a few studies. So some of the improvements are that we have now randomized trials, which is the gold standard when you're thinking about testing efficacy of an intervention. You have blinding of people, so the people that are coding or the people that are testing, they don't know which group the kids are in. And then there's quality assurance. So we're checking things like, well, how well was the intervention done? How well were the assessments done? So much better control. We also have more comparative efficacy studies, meaning we're comparing 2 interventions against each other so you're not looking at this really involved intensive intervention against the control group in the community, which might not be getting anything. So if you can't get a difference in the Cadillac, or whatever the car is here, treatment against, something that's not even existing really, then I think that treatment's not very effective, right? So now we're trying to control how much attention both groups of kids and parents are getting. And several of these studies actually find effects of the experimental treatment over that control or comparison. So that's a big improvement. So we've done a couple of studies with toddlers, so really young kids, which, in the United States, if you have a 2-year-old who has symptoms of autism, you're still not getting very consistent services. As Nathan was saying, it depends on the state. Some states are pretty good at offering services, and some states are horrible. So mostly toddlers have inconsistent services. So we've done a couple of randomized controlled trials on children between 2 and 3. And these oftentimes are comparative efficacy studies. And then we've also looked at very specialized populations. So helping parents who are low-resourced, or helping parents who have minimally verbal school-age children. Those are parents who have been waiting for their children to talk for 5 or 6 or 7 years, and they're still not talking, and they're not very successful at interacting with their children, and they're pretty scared about trying to work with their child. And so they really need some support and some strategies in order to be successful. So what we found with toddlers is that we can improve things like child-initiated joint engagement. So the child is initiating engagement, the parent and the child together are both contributing to the interaction. So it's not just that the parent's able to control the situation and keep the child engaged or in one place, but they're actually communicating together. So this was a really small study. It was the first study that we did was only 38 kids, 2 to 3-year-olds, and we just waitlisted them because we thought that everybody needed treatment, and so we only did a very short-term 2 months treatment and follow-up, and then saw the waitlist group. And what we achieved in that study was increases in joint engagement and in functional play and in responding to joint attention. So here, these little guys are young developmentally, so you're not going to get symbolic play. They're not ready for that. And initiating joint attention is also hard with these little ones. So, we get pretty consistent findings at this age with these outcomes. And let's see. I don't remember where my video, I guess it's coming up. So we've also done comparative efficacy studies where we do kind of parent groups, information sharing, and stress reduction interventions versus this hands-on coaching. And again, we find child-initiated joint engagement goes up in the hands-on coaching intervention, and it doesn't change for the parents who get the information group. However, the parents who got the comparison group, the stress reduction intervention, reduced their stress. And the coaching group doesn't increase their stress, but it certainly doesn't change. Right? So again, it's that balance of what parents need. And this was a larger study, so 86 kids, again, just 10 weeks, 6-month follow-up. Increasing joint engagement, play diversity, and play level. I thought I had a video, do I? Okay, let's show a video just to show you what we're talking about. So for a lot of parents, I think parents in general are very responsive to their children, and the goal is really to sort of tweak some of the interactions to help that child with autism, who is a different child than what you may have expected if you have typical children. So this is a little guy who came in with, I think he's 31 months.
This one is already up. It's finished. Come on. Push hard. The other way. This way. Come on, push. Yay, you did it. That was hard, eh?
So mom is really responsive to this little guy, right? She's talking about what he's playing with. He's playing with something. He's what we would call object focused. She could be there, not there, wouldn't matter. He's engaged with the toy. He's not engaged with her. And so for her, it's just a matter of changing some aspects of that interaction. So in the second video, which is in like 8 weeks, you'll see that, she's sitting in front of him. They're communicating more.
Oh, no, it came out? Can I see? Can Mama see? If I can fix it? No, not see with your eyes, silly. Mama see. Oh, and I'm gonna put this one here. There. Now your turn. Whose turn? Mama turn. There we go. Whose turn? Whose turn is it? Mama turn. Shall I put the doggy or the man? Which one? No, it's my turn.
Man.
The doggy or the man?
Man.
The man? Okay. Now, here.
Man.
Yeah, put the
I
man.
did.
What's that? The eyes.
Why?
Yeah. Put down. We did it! You want to do it more?
I can pull.
You gonna pull? Okay, let's pull then. Whoa, they all turned. All right.
Okay.
Good job.
So she's really responsive to him, but now he gives her much more to be responsive to. And so it's a matter of just teaching her some strategies with toys, because that's what kids do. So there are some behavioral strategies in there, and there are some developmental strategies, right? And I could point those out to you if you don't see them. All right. So with low-resource families, we get the same thing. Child-initiated joint engagement changes. But with these kids who are a little bit older, 2 to 5-year-olds, we actually get increases in symbolic play, as you would expect. The kids are a little bit older, and initiating joint attention. All right. So there's pretty good evidence of improving these kind of core impairments with parent coaching models, using Jasper, but also other interventions that are what would be considered naturalistic developmental behavioral interventions, meaning they're combining strategies which make sense for really young developmentally delayed children. So Brooke Ingersoll has a model that has focused really on imitation, but what she got from one of her studies was an increase in joint attention initiations, which is nice. And Amy Weatherby in her CERTS model got improvement in this kind of category of social communication and also receptive language. So again, these are the kinds of interventions that are going to move those particular targets. And it's really through parents. Parents are important because they can increase the dose of any intervention. So you could see a therapist once or twice a week. That's not going to go very far if the parent isn't continuing those activities at home and across the day. And it's because of parents doing that that the outcomes of the studies are positive. Okay, so there are lots of questions going forward. One is whether or not you can kind of deploy these interventions effectively in the community. And so there was an interesting adaptation of that PACT intervention in the UK that I mentioned before. So the UK is a high-resource country, and they adapted this intervention for a low-resource country in India and Pakistan, and got very significant and similar findings to the high-resource country. So increased parent synchrony and child initiation of communication, which is what you want. You want that child to have access to social partners they can communicate with and to increase their communication. Okay, so there are also some new areas of study. And I think one that's really important for a lot of countries that are just kind of getting on their feet in terms of a lot of early interventions is through telehealth efforts. Because you can expand from a center to lots of different areas, especially rural areas. And there have been some studies with promise, but currently they're very small and they're not very well controlled. But I think in the future that will change. I also understand that there's some behavioral interventions that one can do through telehealth that are pretty effective. I know there's also an anxiety reduction one for adolescents. So using telehealth or Skype or whatever could be a very effective approach. There's also been a shift in thinking more about parents and the stress and the issues that parents are dealing with day to day. And so mindfulness training has become very popular in the States. We do mommy and me groups with 3 or 4 moms of little ones under 5 with autism. And part of the intervention is something we call mindful mommies. So they get a little bit of mindfulness training. And they probably like that part of the intervention the best, right? Because it's really just for them. And then there are studies that are starting, or groups that are starting on sibling well-being. And very specialized programs for siblings. Still too few of those, but they are starting to increase. And for siblings, I think what's important to think about is that is the longest relationship a child with autism will have, longer than their parents. So if they do have a sibling, that's going to be a very, very long relationship. And there are lots of sources of stress for the sibling and things that we need to think about. So sometimes they try to make up for the problems that their sibling brings to the family. Sometimes they worry about their parents' stress with caring for the child with autism. And they also worry about the future and their own responsibilities. So some studies find that siblings report a lot of distress and that their relationship with their parent suffers, and certainly with their sibling. But most studies actually report that there are really positive effects of having a sibling with a disability in general, autism in particular. I have a lot of graduate students at UCLA, and I would say about a third of them have a sibling with autism. And that has brought them into the field, which I think is really a positive and really important way to come into the field, gives you unique information and perspective. So for parents, recommendations for if you do have a sibling of a child with autism, it's to find common interests for siblings, right? So between your child with autism and the sibling, try to find a common interest that they can share. Try to develop strategies for dealing with those challenging behaviors of the child with autism that the sibling knows. So when the sibling or the family is out in public, that sibling knows what they're supposed to do for that challenging behavior. Sometimes we try to protect the siblings and we don't give them information, when in fact what they need is information. Important to create some special time with the typical sibling with parents. Sometimes siblings complain that the parent is working so hard with the child with autism that they don't get to see the parent very often. So having that special time is important. And then talk openly with the sibling. You know, don't hide the problems completely from the sibling. Let them know. Give them information, because that allows them to also help in the situation. There are sibling support groups. Sometimes those are helpful for siblings. And then just be sure that the sibling can also just have a childhood so that they're not taking on an adult role too early. And those suggestions come from a book about siblings by a couple of people out of University of Washington. All right, so to summarize then, there has been really a significant increase in high-quality randomized controlled trials of significant size since 2012. So now we have more evidence that parents are important to child outcomes, that it's really meaningful to have parents know or have a treatment plan with the child. We have a lot more success in improving the parent-child relationship in particular, and child outcomes in social communication. And for older kids, there's been a lot of success in helping the child develop friendships, reducing their anxiety, and improving their transitions. And there are specific programs, right, for parents and for sibling well-being. So mindfulness programs, they're probably good for siblings as well. And then we need to think about how we're going to expand this kind of research, and we're going to need to think creatively. So using non-professionals to deliver interventions and helping parents, using telehealth methods. Somehow we need to sort of throw the net a little bit wider and provide more interventions to more people. Okay, thank you.